All right, so hi everyone. Thank you for joining us today for our Medi-Cal PCP P4P webinar to discuss our 2020 program updates. Since we have a mixed audience today, we're going to ask everyone to hold questions for the discussion portion at the end. So again, everyone's lines are muted and we are recording the webinar today, but we will unmute and stop recording for our discussion. So to jump right in, the topics that we're going to cover today include a bit of context setting, so how we got to today and where we're going next, an update on the P4P program structure for 2020, as well as an overview of the updates to the performance measures, and then next steps.
And as we start off kind of some of that context setting, we did want to pull up an image that folks on the line who have been part of our previous webinars or part of the group that has helped to provide some input on our Pay for Performance program are probably well familiar with. This is the triple aim of healthcare. And so just as we kind of go into today's discussion, I do want us all to keep this image and these three major concepts in mind, because this really does guide the work that we're doing around value-based payment. That is keeping us focused on improving the experience of care and the health of a population through outcomes while managing cost as an organization. So let's really keep this front and center, and you'll hear that those three themes come out as we talk through updates to our program today.
So for those of you who have been part of our discussions on the program or participated in any of our prior webinars, you've seen these concepts before. We've used these principles over the last several years through the development of our value-based payment programs, and these have continued to stand the test of time so far. And this is really somewhat of a filter for how we build and implement our payment models. The model development goes through several layers, and at the highest level, the model itself needs to include the four ingredients that you see here of flexibility, accountability, adequacy, and adjustment. And then we develop our implementation process and timeline to account for the HPSM implementation principles, several of which we'll touch on throughout the discussion today. And then as we review the specific metrics included in the models, we review for each of the elements under the green arrow that you see here.
So hopefully you all had a chance to read the Harvard Business Review article that was sent out titled, "Don't Let Metrics Undermine Your Business." And this article discussed how a company can lose sight of its strategy and instead focus strictly on the metrics that are meant to represent that strategy. That tendency to replace strategy with metrics is called surrogation. And it is easy to do because the intent behind metrics is usually to capture some intangible goal. So one example of this that was shared in the article was the case of Wells Fargo, whose cross-selling metrics were meant to promote their strategy of building long-term banking relationships, but ended up encouraging fraudulent behavior. So despite the pitfalls of surrogation, metrics do still add value because they help to give strategy form, and they provide a defined direction where strategy may otherwise be too amorphous to have an impact. So metrics do remain crucial because they allow us to coordinate behaviors and actions.
And to pull from several additional resources in the literature, we consider the performance metrics as they relate to the 6 domains and 3 types displayed here. And as we discuss the measure updates, you'll notice that they all fit into one of these domains and types. And then to touch on the ways that we try to safeguard against surrogation, particularly in a program like P4P, being that it is very metric-driven, we look to these 3 strategies that were referenced in the Harvard Business Review article that we reviewed. So for strategy number 1, it's involving the people who will implement the strategy in its development. So through our program development process, For 2020, we've involved stakeholders both internal to HPSM and external from our provider community. We had an on-site provider forum in early November where we gathered provider input on alignment across quality priorities and also discussed challenges and benefits of the P4P program structure. This is in addition to the ongoing feedback we've received and have taken into account from our provider community as we've gone through our Phase 1 implementation of the new program. And then what we try to think about through the program as it relates to the second safeguard is how we account for where there are likely to be exceptions to the metric specifications and not letting those get in the way of the strategy the metric is meant to support. For example, through our panel engagement metric, we currently start bonus payments at 50% panel engagement of your continuously assigned patients over the course of 12 months. And in this example, it is to account for the fact that we are balancing various aspects of the strategy behind the measure. So that is to monitor for a certain level of patient engagement that would drive population health management while not trying to incentivize unnecessary utilization. And then for strategy number 3, you will see when we discuss the measure set that we try to include a broad range of metrics across the 3 types and 6 domains discussed in the prior slide.
We also wanted to spend a little bit of time just sharing a bit of how we apply these same principles that we are talking through today around metrics and around setting your strategic framework to the health plan. We won't go into great detail on this today, but I did want to call out and just share in the spirit of transparency the 3 major priorities that are part of HPSM's strategic framework. That is available online should folks want to go into more detail, but really at a high level, our 3 priorities as an organization are access to high quality care and services, strong internal operations, and financial stability as a steward of public resources. And with these 3 in mind, what I did want to call out today is how much the Pay for Performance program and our work with you all as providers ties to the specific goals that we have within all 3 of these buckets. And so we've just highlighted some of those specific goals that we track and measure as an organization to call out how much overlap there is. So again, thinking about how we work with our providers to support meeting our members' needs through services and programs and working between public and private systems, strengthening our partnership with you all to meet those goals of high quality care and services. On strong internal operations, we are always looking for ways to improve on this and how we work with you, our providers. And that includes things like implementing new technology solutions like the e-reports that we'll be talking about a little bit more today. And then finally on financial stability. So really, again, aligning that payment with value is core to the work that we're doing and making sure that we can really sustain our core services for our members while working to innovate and really, again, drive those dollars towards quality.
All right, and to share a bit about how we've put our implementation principles into practice when it comes to a thoughtful rollout, as well as evaluation and updates along the way, this is a snapshot of what our benchmark P4P development and implementation process has looked like over the last several years. We've tried to build into the process not changing too many things too quickly, although it might not always feel that way. And this likely does not include all activities targeted at this program development, and we certainly are not going to go through all of this today, but many of you have been part of these activities, and for those of you who have not been part of them to date, we wanted to do some reflection and share back what has taken place to get us to today and leading up to our Phase 2 implementation starting January 1st, 2020. So now we're going to get into the structural updates for the program in 2020, and that's coming out of all the activity on the last slide through our program development. So these are the structural components of the program and how that is changing from Phase 1, which we are in today, to Phase 2, again starting January 1st, 2020. Several notable changes outlined here. So we are discontinuing our fee-for-service P4P program offering starting January 1st, 2020. So we are moving all Medi-Cal P4P for primary care to our benchmark program structure. And then in order for providers to be eligible to participate in our incentive program, they must have at least 100 HPSM Medi-Cal members assigned to the organization as of January 1st, 2020. And eligibility for participation will last throughout the calendar year, once that threshold has been met by the cutoff date. Additionally, the percentiles for partial and full credit are increasing. We are moving to the 75th percentile for partial credit and the 90th percentile for full credit. And the change to the percentiles was already planned as part of our program evolution, but the timing happens to align with new state requirements on health plans and network performance that you'll hear more about in just a few minutes. We will have 3 tracks that providers will be assigned to based on the age range of your clinic. So we will have 1 performance track for pediatrics, 1 for family practice, and 1 for adults. And the metrics are standardized across the tracks, so there's no longer a component of metric selection. However, we will continue to engage our provider community to align quality priorities as the program continues to evolve.
So through our discussion today, we want to share back with you all how the plan thinks about measure prioritization. As we all know, we can only focus on so many things at any given time for them to really be meaningful and for us to make any real impacts. So we're going to walk you through the various layers of consideration that we go through for identifying sources of metric prioritization specifications, and then we will review the final set of metrics based on those 2 things. So these represent the criteria that we have considered in metric prioritization. Firstly, we considered compliance and regulatory needs, such as the state's Managed Care Accountability Set, or MCAS, which we'll discuss a bit more in a moment. We considered external quality reporting and priorities, such as HEDIS. We then considered internal quality reporting and priorities. So this would, for example, be HPSM programmatic initiatives, or measures that support those. We also considered internal administrative priorities. This would be, for example, gathering capitated encounter data, which HPSM is required to report back. And then finally, we considered our current network rates and areas of potential improvement. And so we also wanted to review the sources from which we gathered measure specifications. The first here is the State Managed Care Accountability Set, or MCAS. As you all may know, under the new governor, the state has been increasing its focus on managed care plan performance, especially focused on preventative care. And so as part of MCAS, plans are held to the MPL, or minimum performance level, on certain measures. And in 2020, the MPL will be the 50th percentile of plan performance statewide. And if the plan does not meet the MPL on certain measures, it will be subject to financial penalties and corrective action plans. So this has been one priority source for our measures. We have also pulled many measures from HEDIS. And then we've also considered measures that may be included in MCAS in the future, as well as HEDIS metrics, where we have areas of improvement. Again, we've considered plan administrative priorities, for example, encounter data submission, timely filing of claims, and membership volume. So we wanted to dive a little bit more into the State Managed Care Accountability Set metrics. We have identified at-risk measures, which are measures that will be held to the MPL in 2020 and where the plan did not meet the MPL in the prior year. So these are well care visits for children 0 to 15 months, adolescent well care visits, the asthma medication ratio, adult BMI, and then within comprehensive diabetes care, A1C testing, and poor control. And then we've also included measures that are a focus of MCAS but may not be at risk currently. Those are chlamydia, timeliness of prenatal care, plan all-cause readmissions, and controlling high blood pressure.
All right, so that brings us to the actual measure sets themselves. We're going to go through all of them for all 3 tracks, and again, the tracks are designed by age range of the clinic, whether that's peds, adults, or family practice. We are not going to go into the detail on specifications for individual measures today, but we want to make sure that everyone leaves here with an understanding of the program measure updates for 2020. Anything bolded in the middle column is new or updated. So what we have on the left in the gray box, those are the applicable measures in our benchmark program today for pediatric patients. The middle box are the new payment measures for 2020. So again, anything bolded in that middle green box is new or updated. And you'll notice that it says at the top 11 measures assigned for payment. However, there are 12 listed, and that's because we have the panel engagement measure. It's measured separately, and it's updated quarterly for payment through our monthly capitation process. So the payment measures are what they sound like. These are the measures that will count toward your year-end bonus payments for 2020. And then the reporting metrics are also a priority for HPSM, but we're not yet including them in the payment calculation. And that largely has to do with the measure prioritization filters that we've previously discussed. And we still want to report these back to help us collectively review where there are member-level gaps and opportunities for these measures, even though you won't be held accountable in 2020 for these measures to count toward your incentive payments. Also, these same principles apply to the adult and family practice tracks as well. So a quick overview of what we have available today that would be applicable to adults in the benchmark program. And then what is new or changing for 2020. So again, in the green box on the left here, we have the applicable adult measure set for 2020, and as you can see, nothing is bolded here. So these are all currently in the program today and have remained a high priority for HPSM and our members. And then we do have a number of new reporting metrics that we will be sharing back with our providers, again, for the same principles just discussed for the pediatric track. And then for family practice, it's everything that we have in the benchmark program today, as it does combine peds and adults. And then for our family practice clinics, here's what we will have in place for 2020. Again, everything on the left will be the payment measures, a few updates there, and then several updates to what will be reported back. So we can also come back to those slides if it would be helpful for our discussion portion, and we can also make these slides available after the webinar today. We're also going to be updating our full program guideline document, and so that will be made available in early 2020 or as soon as possible. And before we wrap up, we just wanted to give a quick reminder of some of the various reports that are available. So these are meant to help providers manage their panels and track progress toward the performance metric. And the 2 reports for real-time monitoring are the progress report and member detail reports. So for those of you who have been closely involved in the program so far, we know that we've got ongoing data capture and validation needs, and that is going to continue. It's going to be an ongoing work in progress, and we truly welcome any feedback on how we can improve in this regard, and we would love to even hear some of that today as we move into our discussion portion. The reports for 2020 are going to look similar to what you received today through e-reports. We're going to be adding flags for which measures are payment or reporting by track. And the reports are standardized for our entire Medi-Cal primary care network. So they will include all measures that we've just discussed, which is why we are adding in the flags. And again, in our discussion portion today, we welcome any feedback that you have on what else would be helpful for you. So a quick note on some next steps. So everyone should have received our PCP contract amendments. Those were sent out in early November. We're going to be sending out a reminder early next week about this. They are due back to HPSM on Friday, December 13th, which is next Friday, so a week from today. In the fax that we send out, there was also a cover sheet that had an outline of the amendment summary. So please reach out to Provider Services if you have any questions about any of this. One important thing to note is that you'll see in the agreement in Attachment B, which are the capitation rates for your base pay, that in order to be eligible for HPSM primary care capitation in 2020, you must have at least 50 Medi-Cal members assigned to your panel. These capitation payments are going to be reviewed quarterly along with the panel engagement bonus payment updates. So right now we are reviewing that for January 1st, 2020 capitation. And then finally, when the updated HEDIS benchmarks are available, which we anticipate to be sometime soon, generally mid-month, we are going to be updating the program guidelines. Those will be posted on our website. We can send out a notification once that's been posted. We're going to be updating our report specifications, and the first reports are targeted to be released in March of 2020, and that has to do with the fact that we won't be receiving eligible claims for 2020 dates of service until January. And it's also what we've built into our project timeline for what we think is going to be feasible for making all of those updates based on these changes. And then there will continue to be the ongoing testing and validation of what's being shared back in those reports, which we will be partnering with you all on. Also, you will continue to receive monthly reports for 2019 data as we continue to receive claims for 2019 dates of service through April of 2020. And a reminder that the cutoff date for submitting claims to count toward 2019 P4P credit is March 31st, 2020. We do plan on continuing with our attestation process for any of the multi-year look-back measures, same as what we did for the 2018 payment calculation, and we will send out a provider notice on this in 2020 with additional information on the measures that qualify for attestations as well as the timeline for submission. And since the measure set did not change from 2018 to 2019, it's safe to anticipate that that process will look similar for what was in place for 2018. Also, here's a bit of contact information to reach out to any one of us or anyone in Provider Services with any questions about any of the information that's been covered today, anything on the contract updates, anything on the reports or how to access the reports. So with that, I am going to end the recording, and we're going to open it up for discussion. So I'll be unmuting everyone's lines. And again, thank you all for participating in our discussion today.